These were subjective responses. The patient said, I think I got better. When you asked them what that getting better was, most of them said I had more energy, or my tingling seemed to go away at times, or I had less pain. But whether the disease itself actually responded wasn't what they were interpreting. When we looked at the evidence for objective measures of disease improvement, 3/4 of those who said they responded had clear-cut objective signs of improvement. They walked better, they could get up from a chair, they didn't need a cane or a walker that they needed before. Very clear evidence of improvement. Those who did not have the disease, only about 15% of them had some objective signs of improvement, walking better, which could happen if your pain is less, it just speaks to the fact that we need to be more rigorous in our diagnosis. There are now validated measures to longitudinally look at patients with CIDP. So a study that we were involved in called the Perinome study showed that using a grip measurement, grip strength measurement, is very helpful in assessing patients and whether they respond to treatment. And a disability scale called the RASH Outcome Disability Score is very helpful to survey. It's a very simple questionnaire. Using those two measures along with other manual muscle testing and gait you can usually determine whether someone's getting better or not from the disease. And I strongly urge physicians to work with their patients so that everyone knows what the objective signs are that is going to be looked for in terms of whether the treatment works or not. I think most of the disease CIDP patients are getting weak. And I would think if your patients are getting weak, then I think it pays to get a neurologic assessment, whether that diagnosis is going to be CIDP, or whether it's going to be multiple sclerosis, or whatever, muscular dystrophy, or I think neurologists are an appropriate referral for patients who are getting weak, because a lot of times it can be treatable, and it also causes a lot of impairment, and it's very difficult for a non-neurologist to deal with the spectrum of the disorders, which are primarily neurologic causing this. Jeff and I are looking at more detail of the electrodiagnostic features that people are confusing. I think it means educating our patients and educating our physicians about the correct diagnosis of CIDP. The other aspect of it is that there are, besides the classic version that I mentioned, there is also what we call atypical variants of the disease. And most of the misdiagnosis came in the atypical variants, whether they be multifocal, such as Lewis-Sumner syndrome, or sensory variants, or what's called the distal acquired demyelinating sensory neuropathy, or DADS syndrome. Those are the ones where people misdiagnose. So one of our pleas is that if there is an atypical variant, think very carefully about your criteria and maybe get a second opinion from centers of excellence which are available. The GBS CIDP Foundation has designated centers of excellence based on clear-cut investigation, research, and experience in the disease.